Hello, I'm Michael Martirano, your West Virginia Superintendent of Schools. Welcome to the West Virginia Department of Education and the Charleston Area Medical Center's virtual healthcare experience. In a day where technology rules the world, we are taking full advantage to better serve you, our students. Using readily available technology delivered to classrooms, this project introduces high school students like you to careers in healthcare. The project uses real-time technology to link health science classrooms to the real world of hospitals. By participating, you are proving yourself to be a self-directed, motivated student, preparing for your future in healthcare. Through this program, you will be transported into an operating room suite of the Charleston Area Medical Center to participate in an actual surgery, teleclass live in your classrooms. As the surgeons operates, you will apply the knowledge and skills gained through your academic and health science education studies. After viewing the surgery, you can ask questions by tweeting, emailing, or calling the surgeon. On behalf of the West Virginia Department of Education and the Office of Career and Technology Instruction, we hope you find this educational experience beneficial. I am pleased that you have taken the opportunity to participate and hope you enjoy this virtual learning opportunity. Thank you and have a wonderful day.
Hello and welcome to Imagine You, a virtual healthcare experience. During this webcast, you'll take a virtual step into the operating room to see a surgery being performed at CAMC. In addition to learning about the procedure, you'll get to see how healthcare professionals are using their knowledge and skills to improve patient care. The healthcare field is always growing and expanding. At this point in your education, you're probably considering what your career choice may be. We hope this presentation helps you see how you might fit into one of the various roles of providing patient care. In recent years, government regulations have limited student access to job shadowing and viewing procedures. This virtual healthcare experience is an innovative way for you to see surgery while still protecting the privacy of our patients. We're very excited to bring you this program and look forward to your feedback. Thank you for spending your time with us today.
I've seen many young children and teenagers during the course of working in the critical care department. They come in as traumas, they have traumatic brain injuries, some are left on life support in vegetative state, and I think that you really need to be aware as you're in high school and going through many changes, thinking about what your career path's going to be, that split second can change instantly, and it has so for many patients that I've taken care of. There's a lot of peer pressure, and so sometimes you just have to say no.
This is Dr. Steve Holosi, an emergency medicine resident at CAMC, and I know firsthand the dangers of distracted driving because we see the devastation it causes on a regular basis. Texting while driving is a growing trend and a major cause of accidents. So please, do yourself, your loved ones, and fellow drivers a favor. Don't text and drive. After all, it won't kill you to put down your phone.
This message has been brought to you by CAMC.
Hello, I'm Dale Witt from Charleston Area Medical Center. Welcome to our Imagine You webcast. We're excited because we have schools participating from all across West Virginia. We appreciate all the students and faculty who are watching, and we anticipate others to be watching later on after the program is archived. Anytime during the live webcast, you can email your questions to us at healthinfocenter@camc.org. That's healthinfocenter@camc.org, or you can tweet your questions to us. Use CAMC_HS, CAMC_HS, and use the hashtag ImagineU. Please include your school's name in the email subject line or the tweet so we know where the questions are coming from. And don't forget to complete the survey online after the webcast. It's at this same website you're watching now, camcinstitute.org/ImagineU. Now, in a few minutes, we'll show you the surgery, but right now I'm pleased to introduce Dr. Audrey Hunt. Dr. Hunt specializes in ophthalmology, She graduated from the University of Texas School of Medicine and completed an ophthalmology residency at Loma Linda University Medical Center. So welcome.
Thank you.
And she joined the CAMC Physician Group ophthalmology practice in 2014. So thank you for taking the time, for allowing us to video the surgery, and for being here this morning to talk about it.
Absolutely, my pleasure.
So first, tell us a little bit more about your background, why you wanted to become a physician and this particular specialty.
Sure. So initially, I actually graduated with a music degree from when I went to college. I played the violin, and when I went to a very small town, I didn't have a symphony or an orchestra or anything to play with. So I felt like I needed to do something that would contribute to society, and I felt that while music gives us that, I wanted to give more. And so after going through a little bit more schooling after finishing college, I got my prerequisites, and I wanted to be involved in the healthcare field. Over time, I went on a mission trip that actually was a medical mission trip, and this mission trip really exposed me to what it's like to help someone that actually needs you and be a contributor in that way. So I went to medical school, and when I was in medical school, I was exposed to ophthalmology. And as you will see, ophthalmology does the coolest surgery in the world. So it's just amazing. And when I was exposed to that in medical school, I was like, I need to do this surgery because this helps people so much.
Right.
And I was so excited to do it, and it's a very competitive field, so I felt very lucky to get into ophthalmology and be able to help people with their eyes and eye disease. It affects their whole body as well, so looking into the eye, you can help people in their holistic approach for their entire health. But then you also get to do this really cool surgery. So,
well, let's talk a little bit about the procedure that we're going
Sure.
to see here in just a minute. Maybe explain what happened with the patient, why she needed to come see you.
Sure.
And I know you've brought some things to help show us. Yeah.
Yeah. So we'll start out with a little bit of eye anatomy. Before we do look at the surgery itself, then we can look at this eye here. And it's a very cool eye model. This is the front part of the eye, back part of the eye. And once we open up the eye, which we'll do in surgery too, a little bit differently, but you can see the eye structures on the inside. And the front part of the eye has the cornea here. And then behind the iris, which is the color part of the eye, you have a lens. And it does what any lenses do. The lens here, that's the natural lens in the eye, will focus light in the back. What actually sees light for you is the retina. And as the retina perceives light, it sends the information back to the optic nerve that goes back to the brain. So the part that we're going to be focused on is the front part of the eye. That's the part that I specialize in, which is general ophthalmology, and specifically cataract surgery. Well, what is a cataract? A cataract is when the natural lens of the eye becomes cloudy. So I'm going to use this other eye model here for us to talk a little bit more about cataracts. And as we talk about cataract, so the natural lens of the eye now, instead of being a nice clear lens that focuses light in the back, now has some sort of opacity. So once the natural lens of the eye has these opacities, you can't really see through that. Right. So there are different kinds of cataracts. This particular one is focusing on the outside of the lens, which is the cortical part, so it's a cortical cataract. But once it's, the cataract is established, then we have to remove it. And during the video, what we'll see is how we're taking out this cataract. We use little tiny instruments. You're going to see a perspective from the front part of the eye. The surgery is going to be on the front part, and the patient is obviously going to be laying down, so we're going to be operating here. So once we take the cataract out, then as I said, the job of the lens is to focus light in the back. So if you just take the cataract out, you're really not going to be able to see anything because you can't focus. Right. So this is where we put an implant that is a clear lens. It's an acrylic lens that actually will help us focus light in the back again. And this is an example of what a lens looks like that we put in. This is obviously much larger than the one we put in, but it's an acrylic lens that now, instead of having the opacity of the cataract, it gives you a clear view to the back of the eye. This might be a little bit hard to see, but can you tell?
It's a smaller version of what you just showed us.
This is the actual size of what goes inside the eye. So That's the part that will go inside the patient's eye, and you will see it in the video itself. As we deploy this part inside the eye, it's going to be folded in like a little taco, and then when it goes inside, it will open up again so that it will stay fixated in the back part of the eye, and it will be stable. And you only have to do this surgery once.
Great.
So.
All right, well, thank you for that. Remember, we want to hear from you, so send in your email anytime, healthinfocenter@camc.org, or anytime during the program. Tweet your questions to us, CAMC_HS, and remember to use the hashtag ImagineU. So before we start the video, we have to remind you, because some people will find it a little bit graphic, but we have a very nice view of the procedure today, close-up details of the eye and of the surgery. So you may want to turn away at some point if it starts affecting you. But let's go ahead and start the video, and we'll start from the beginning, and you just walk us through what we're looking at.
Okay, so when we're doing cataract surgery, an important part of it is for you to be able to see what you're doing. And so while that seems to be pretty obvious, how we do this is different. We use a microscope, and that's what we're showing right there. The microscope makes the view about 10 to 16 times larger, so we can see the details of the cataract surgery. And so as the patient comes in, what you have there in the middle is our patient. I'm coming in. I'm right there to her right side. I'm introducing myself in the operating room so that the patient knows that their doctor is there. And they've met us multiple times in the clinic, but during the operating day itself, they may feel a little bit nervous. So this is an opportunity for them to know that their doctor is there, for them to be reassured. Right now, the circulator is making the eye sterile, cleaning it up with iodine. And now I'm here with the surgical tech. He and I are going to be making the eye completely sterile now with the draping, and we'll be about to start the cataract surgery. It's a very important part of the procedure is to make sure that the area we're operating on is sterile. And this is the setup. Here, I'm looking through the microscope. When I'm doing cataract surgery, you don't look at the eyes themselves directly. You're looking always through the microscope so you can have the best visualization possible. The machine that we use is a phacoemulsification machine, and that's a big name for an ultrasound machine that breaks down the cataract. And as you can see there, there's an IOP measurement. It says 55 there, and that's the pressure in millimeters of mercury that the eye is undergoing at the time. So at this point, we're just situating ourselves here, making sure that we have a good view. And then I'm sitting comfortably for the procedure itself. And now we're getting to see my view with the microscope here. And as you can see...
So just so the students realize, this is what you see.
Yeah, exactly. That's what I see. And there's the surgical tech. He's going to be handing me all the instruments through the surgery. And as you saw in the previous picture, he can also see either through the microscope, there is an assistant microscope viewer there, or he can look through the main screen, which is showing to the entire room what part of the procedure we're on. So right here, I'm using a ring to stabilize the eye with my right hand, and I'm making the opening inside the eye with my left hand with a knife. It's a 1 millimeter opening, so it's a very tiny opening. It's very, very small, so that we can start to introduce different chemicals and also the instruments that we need inside the eye. What I'm using there to irrigate the eye is balanced salt solution, and that's to make sure that the view remains clear during the procedure. Right now I'm talking to anesthesia and telling them to keep the patient comfortable, for them to put them a little bit a higher sedation so that they can be comfortable through the procedure.
Is the patient conscious during the procedure?
Yeah, the patient is awake during the whole time, and I'm telling them where to look and what to do. Right now, I'm introducing a little bit more of anesthesia into the eye. So before we start the procedure, we put anesthesia on top. So it's topical anesthesia, some drops in the eye that make it numb, And then just now I put in some more numbing inside the eye itself, because the iris is a sensitive tissue inside the eye. So at this point I'm going to introduce a dye, and this dye is going to stain the anterior capsule of the lens. Once it stains the anterior capsule of the lens, I am able to see it better when I'm trying to make an opening to it. So at this time, I let the dye stay in the eye for about 20 to 30 seconds, and then I'm going to wash it off with balanced salt solution again. So through this 1 millimeter opening here that we made in the beginning, I'm washing off the dye from the anterior chamber of the eye. And I also put a little bit of posterior pressure. So I'm pushing down a little bit on that opening, because if you just put liquid in the eye without giving it a chance to come out, then the pressure in the eye is going to just be very, very high, and the liquid is just going to stay in. So there's a two-way entrance and exit there of fluid. So the fluid that I'm introducing is coming in, and the dye is coming out. So now you can see the color part of the patient's eye again, because the dye has been removed from the anterior chamber, and it's just now staining the anterior capsule of the lens. I'm introducing Viscoelastic, which is a substance now that keeps the integrity of the eye, but it's transparent. That's very important, because once there are openings in the eye, as you can imagine, the eye is going to have a tendency to lose pressure. But this viscoelastic that I just put in is a transparent substance that keeps the pressure in the eye and doesn't allow all the fluid from the inside of the eye to come out. I'm going to use a keratome here. This is a special blade. There's a three-way entrance into the eye. So I made the first cut, and now I'm going parallel to the cornea, parallel to the curvature of the dome of the transparent part of the eye. And now I'm going to go inside the eye with the keratome. So it's a three-way cut, so that at the end of the surgery, this cut will close on itself just because of the pressure of the eye.
We have a question from Brooke High School.
Okay.
Why is the patient kept awake during this surgery?
Yeah, so that's a great question. So general anesthesia itself has its own risks. And general anesthesia is riskier than just leaving the patient awake. So that's the main reason to keep the patient away on a short procedure like cataract surgery. Usually cataract surgery will last between 10 to 20 minutes at the most. So if you can allow the patient to stay awake, then you don't have to put them through general anesthesia. And yes, they are aware of what's going on. And as the surgery is going, I will tell them to look different places. And our patient specifically here, she was having a little bit of trouble keeping her eye under the microscope. As you will notice, she's drifting away towards the bottom of the screen. And for her, she's drifting away from me, because it's natural for you to drift away from something that you think is going to hurt you. Although she's not in pain, she's turning her face to her left side multiple times. So during the procedure, she being awake is helpful to me, so that I can tell her, look back here, or look down here, or I will move your head a little bit. So those are the things that will allow me to converse with the patient while they're undergoing their own surgery. But they're not in pain, they're very comfortable, so that's very helpful. So through this part of the surgery right now, we're making an opening on the anterior capsule of the lens. The lens sits, as you see, I'm making that opening there. I had already stained with the dye, and now there's a round opening in the front of the capsule. And basically, that's the way that I can access the lens, or the cataract, which is another name for the lens once it becomes cloudy. And that opening is going to allow me to introduce instruments now towards the area where the lens is located. So this instrument I'm using right now is full of water and separating the lens from its capsule through water. It's called hydrodissection and hydrodilation. Right now we're using the phaco machine. So the phaco machine is the one that we talked about in the beginning. It's the ultrasound machine that's going to break down the cataract into tiny pieces. And this particular needle here that I'm using has a dual purpose. So first of all, it's breaking down the cataract into tiny pieces through the ultrasound. Then it's sucking all the material from the lens through a tubing back to the machine. And also, it's introducing liquid to the inside of the eye so that the pressure in the eye remains constant throughout the procedure.
We have a question from Cabell Midland High School. What if the patient moves their eye in a different direction than what you asked them to do? Is there any harm?
No, there's no harm, but it's a good question. It's something that sometimes we have to face, and basically you have these different instruments that stabilize the eye and make sure that the eye is looking where you need it to look. If the patient cooperates, then it's easy because you can just tell them where to look. Right. But if they're having trouble, or if they can't really follow the commands, or they're very nervous, then there are instruments that we can use to stabilize the eye. And the very first one that I used was a Thornton ring. You saw that ring is not completely 360-degree ring, but it stabilizes the eye. So right now I have two instruments in the eye. One is the phaco instrument that is sucking the cataract and breaking it down. The instrument that's in my left hand, and it's on the right side of the screen for you, that one is a Connor wand. It's sort of like having a little finger inside the eye, so it can help me direct things towards the tip of the needle and also prevent the tip of the needle from reaching into things that I do not want to be sucked inside. And we're removing the cataract right now, as you're seeing. I broke it down into quadrants so that I can get it out from that smaller opening that we made in the anterior capsule of the lens. And the phaco machine is essentially breaking down with the ultrasound and sucking out everything through the vacuum, almost like a vacuum at home itself, getting all the particles that we don't want. And now I'm making the last cut here. You had 2 halves, and now you have just the last half of the cataract that I'm breaking down into 2 other quarters. And now these quadrants, after they're separated, I'm going to remove them as well.
Now, when you were showing us, when you put the lens back in, why is it an acrylic instead of some other material?
So they started out a long time ago when they were doing cataract surgeries with glass, and because they want to have a transparent medium. But over time they found that some of these different materials need to be inert in the eye. Something that you introduce to the eye, you don't want that to elicit an immune response. Acrylic is a very inert material, so it's not like some of the other materials that could cause it to have immune response, and also because of its quality of how it bends light. So it's an ideal material that's not going to create immune response in the eye, and also it's going to give the best quality of vision, good light refractive properties to bend the light and go back to the back part of the eye.
So while you're doing the work on the patient, this is a question from Brooke High School, can the patient see what you're doing? Yeah,
they can see it, but they cannot see in detail. What they see is a lot of lights and a lot of water, and just the different, sometimes when I'm introducing the new lens in the eye, they can see a rainbow-like effect, a prism-like effect. They can't see anything in detail because we're inside the eye, so they see shapes, colors, and lights. So the nuclear part of the cataract was removed, and right now I'm removing the cortical part of the cataract. This is the part that's really stuck to the capsule that holds the lens in place. And once the nuclear part is removed, that's the densest, hardest part to get out, and we use the phaco machine with the ultrasound. Right now, we're just using the suction part of the machine, so there's no ultrasound inside the eye to break down anything. We're just kind of very gently peeling away the cortical skirts of the cataract.
What happens if you cannot get the cataract out, or if, is there an instance where the surgery does not work?
So usually you're able to get the cataract out. If there is a complication, and let's see this bag that holds the lens and also is going to hold the new lens, if it breaks during the surgery or parts of the cataract fall in the back part of the eye, then you will have to go back in there with a different surgery to make sure that it's removed. The lens sits inside a bag, which is this bag that we opened in the beginning. And so the lens in itself is a very reactive tissue in the eye. So if it's left in place after you open that bag, it will create a very, very severe immune response from the eye. And that's not something that a patient can tolerate. You have to remove the whole cataract.
Okay, so once you remove the whole cataract and you put the new acrylic lens in,
here it goes.
That's what you're putting in right now.
Yeah.
Will the patient be able to see clearly as soon as it's in there?
Yes, that's if there are many different media in the eye that need to be clear once. One second here, let me just talk about this. We put it in like a little taco, like I talked about in the beginning, and now this implant is inside the bag that the usual lens, the natural lens of the eye sits on, the cataract sits on, and now we're just making sure that it sits centrally, and that those little haptics that they deploy properly and not in a place that we don't want. Anyway, so going back to your question, to their question.
Right.
So what was it again? Sorry.
Well, while we're on this right here, is there a chance that this new lens that you've put in can move out of place or anything?
Yes, it can. So it's important that you place it properly to begin with, and the diameter itself that those haptics cover is usually the diameter of the lens bag. So they're going to be pushing against the bag of the eye, the natural bag of the eye, and remain in place stable. But it can move, for instance, if the bag or the cataract was so big that bag had stretched out. And if it was stretched out, then it can be larger than the diameter of the haptics, in which case it can shift inside the eye, and that has happened.
Well, what are the risks of this procedure?
So, like any time you break skin, you have the risk of an infection. Infection in the eye is very rare, but it can happen. You have a risk of bleeding. It's a very rare risk as well, because as you saw, most of the cuts that we make are not in areas where you have a whole lot of blood vessels. There is a risk of needing additional surgery, as we talked about, if the whole cataract is not removed or if there's a complication that causes it to fall to the back of the eye. And there is a risk of a retinal detachment. So that's very rare, but 1 in 100 people could have a retinal detachment following cataract surgery. And that's because we are destabilizing the eye during the surgery itself with these changes in pressure, and also we're introducing trauma, mechanical trauma itself to the eye.
Right.
So you could have a retinal detachment. That's very rare. So most commonly, you will just take a little bit to heal. I now remember what the question was. It's if they see right away after the surgery.
Right.
And it depends. Right now, this surgery was pretty straightforward, so the patient is going to see very well after the surgery. But if you have any complications that affect the cornea so that it's swollen, then it's not going to be able to have a clear view. It's going to be fuzzy and blurry for a little bit until that clears out, which is usually within a couple of days. But the patient is going to see clear already just because you removed the cataract.
Okay. So you're just cleaning up a little bit here.
So at the end here, I want to make sure that the eye is closed. We talked about that wound, and that wound is self-sealing. Both of them are. So you want to make sure that there's no leakage, that the wounds are closed. And the wounds were closed. Everything went well. This case had no complications. And we were able to remove the cataract and put the new implant without any incidents.
So, we're after the surgery now. Will the patient have any pain or discomfort or anything from this?
They shouldn't have any terrible pain. And I say that because we made a cut in their cornea, and the cornea is very sensitive. And so they may feel, after the anesthetic wears out, that there's an eyelash, or almost like there's something in the eye. Okay. So it's not going to be pain per se, but they may feel like there's something in the eye. The majority of people don't feel anything, but some people do talk to me about the next day and say, yeah, I felt like there was an eyelash there for a while. And then once that cornea starts to heal, which it starts to heal right away, then they stop feeling that.
Can you go back and explain what is it that causes this cataract?
Yeah, so that's a good question. The majority of the patients that I treat are having age-related cataracts. So if you live long enough, then nature is going to give you some gifts,
right,
and that's one of them.
Okay.
So starting around age 40, people start to have a little bit of opacity in their lens, and that has to do with basically the proteins which make up the cataract are starting to be not as clear as they used to be. So within the lens itself and around the lens, there are many mechanisms that keep that lens clear. So basically, the antioxidant properties of the eye itself to keep all of its media clear. But once you hit age 40 and then on, those antioxidant mechanisms start to deteriorate somewhat, and then you start to have a little bit more opacities in the eye, opacities particularly in the lens. Once you are 50 or 60 or 70, some people even in their 80s, that starts to really cause you to have symptoms such as glare, starburst effect around light. You're not able to see clearly. People will describe it, I can see it, but it's just, it looks like looking through a dirty windshield. I can see, but it's not clear, or it's dim, or there's a fog. And once that starts to happen, that is an indication for us to remove the cataract, because it's starting to affect the functioning of the patient.
Right.
But there are other reasons why people could have it. Age is just one of them. They could have it for trauma. If you violate that capsule that's holding the lens, you could have a traumatic cataract right away. And that could be through a penetrating wound, a perforating wound, or it could also be just from blunt trauma. Okay. Steroids can cause people to have cataracts. If you have to have a condition, let's say rheumatoid arthritis or lupus, where you're having to use steroids, that could make it easier for you to have cataracts. And then there's genetic instances where people are born with cataracts, or they develop cataracts very, very fast, early in their lives. And so those are some of the main ones, main reasons, main etiologies of cataracts.
Now, is there anything that the patient has to do after the procedure? Is there any therapy or anything?
Yeah, so a little before surgery, about 3 days, and after surgery, they are going to use drops. So different ophthalmologists have different regimens, but basically what we're trying to curb is the inflammation that could happen after surgery. So they're going to use drops for about 4 weeks after surgery. The first week is a more intense regimen, and then after that it tapers down so that we can control the inflammation, but we're also taking them off the drops.
Okay. Carver Career Center asks, when you put the artificial lens in, does that change your perception of color, light, or will you see the same as before?
Yeah, it does change, and patients will tell you, and I think our patient here is going to talk a little bit, and she will tell you that you don't realize how much a cataract affects you until you actually have the surgery, because now that you have this clear implant, then you see, especially because we do one eye at a time, that with the eye that you have the cataract surgery, you're seeing brighter colors, you're seeing more detail, and the eye that still has the cataract, obviously it's a lot dimmer. So yes, patients will tell you that there is a difference in the way that they see light, the way that they see colors, the way that they see the world.
Okay. Well, it doesn't always work out that we can talk to the patient after the procedure and everything because of our schedules, their schedules, doctor schedules and everything. But we were fortunate this time to be able to interview the patient the day after the surgery. So let's take a couple of minutes and hear her thoughts about the procedure.
I started to notice changing back when I was in my 50s. I'll be 67 in a week, and things started getting blurry. I had to go buy over-the-counter glasses to read, and that would help, but I couldn't read my books because it would give me headaches to wear them, and so I could only read for a little while. I was anxious. You could tell my blood pressure was up. You know, little things like that. But that's little things compared to I can see now. You know, it's getting clearer and clearer. And so I'm happy that, you know, I made the decision to have it done. I was surprised because everything's clearer, brighter. Colors are so vivid. You know, I was looking at my DS and was playing my game. And it was like playing a new game, the things I saw in it that I hadn't seen before, you know, things like that, and noticing in the drive up, I was noticing how far off the signs was, and I could read them, you know, and it was like a miracle, really, you know, it's like rebirth and being able to read again. And I advise anybody that was having this problem to go ahead and, you know, have it done because it's a gift back to you to see.
Okay, so with these acrylic lenses, do they last forever?
Mm-hmm. Yeah. So basically, once you do cataract surgery, you just do it once. So it's the implant is going to be in your eye for a lifetime. And very rarely, when patients have some sort of complication or something happens to the implant itself, you would have to do an exchange. And very rarely, some patients do cataract surgery where they actually have a special implant that corrects for their distance and near vision. Those are a little bit different than the standard lens that people get. The majority of people get a standard lens. But if they get a special lens and they cannot get used to the way that that new lens interacts with their brain, so they're having troubles adapting to it, then you can do a lens exchange where you get that lens out and you put a new one in. But usually this implant is for life. So.
Okay. And one of the questions we had via Twitter was, can you do this procedure at any age?
You can do it at any age, and we don't recommend that people who have clear lenses do a procedure like that, because if your lens is clear, then presumably you're seeing well. But there is an indication for you to do a clear lens exchange, and that will be to change the refraction in the eye. Let's say someone once was nearsighted or they're farsighted and they want to have perfect vision. So you can do an exchange of a clear lens cataract extraction, or it wouldn't be a cataract extraction, but a lens extraction.
Right.
But yes, you can do it at any age. There are little babies that have to have cataract surgery, and then you can be in your 90s and you can have cataract surgery. But usually you will have cataract surgery sometime in your 60s or 70s when this lens that's now becoming cloudy and became a cataract is no longer allowing you to function well, to drive, to watch TV, to read, to do near work like sewing, or people have different hobbies and you can't do the
Right.
things you like, so then that's when you need to have it.
Another question we had from Twitter is there a point where the cataract is just so severe that even this procedure doesn't help?
No, I don't think so. I'm trying to think of one instance where that would be the case. I just did a cataract surgery a few weeks ago where the patient could only perceive light. So the cataract was so dense and so white and so mature that they couldn't even see besides light. So it was hard for them to even see any movement of the hands. And once you remove it, you're taking away that opacity, and so you should be able to see again. If there's a problem in your retina or your optic nerve, then it doesn't matter what I do to the cataract, it's not going to make you see again, because then it's not a problem in the front part of the eye where we can manage the cataract, it's in the back part of the eye.
Right.
But if it's a problem that's isolated to the cataract, it doesn't matter how dense it is, we can remove it, and then patients should be able to see again.
Explain to us a little bit about the diabetic retinopathy screening that you do, and how you use telemedicine to reach patients in rural parts of the state.
Sure. So this is a program that started in November of last year, so it's probably going for about a year now. We are able to see patients through the screen, and the remote sites, which now we have 6 of them, they're within maybe 1 to 3 hours from our facility, and over in that remote site, they will have a nurse or someone that's trained in taking pictures of the retina. So it's a different part of the eye now that we're talking about. So not the front of the eye, not the cataract or the lens, but they are taking a picture of the retina and the optic nerve. And then they send that to us, and we have an interview with the patient live. So we talk to the patient, and we look at their pictures, and then we advise them on what we think should happen. And the majority of the patients will be for screening, for us to even see if there is any diabetes in the eye. So we do that first screening, and if the patient is doing well, we'll do the screening for another year, so we see them every year. But if the patient is having trouble with their eyes, whether it's a problem with the diabetic retinopathy or maybe a problem with their lens, or we look at the optic nerve and we see that there's a problem, then we'll recommend that they see either a local ophthalmologist there, or we can recommend that they come see us so that they see us in person. We can address those specific problems. So it's a great program because it allows all of these different remote areas that don't have sometimes access to an ophthalmologist to have ophthalmology present. It's a live interview, and then we can recommend any further treatments that the patient may need.
Technology is a great thing.
Yes,
sometimes.
it is.
We have a question from Mingo Central High School, and what percentage of eyesight is restored after the surgery?
So 100%. That's the goal. But as we talked about in the beginning, and I'll be brief here with the models, but we have the front part of the eye, and we have the back part of the eye. So if the patient only has a cataract and we put the new implant in, then that's taken care of. But if the patient has a problem in the retina or a problem in their optic nerve, it doesn't matter that we remove the cataract, they're still going to have limited vision. So whatever vision they started out, that's the vision that we can restore. Okay. So it's 100% of that. So if they already had limited vision to begin with because of macular degeneration, or they had glaucoma, or they have a problem in the back of the eye, then we remove the cataract, we give them a new implant, but their vision is going to be limited to what the back of the eye can do.
Okay. And the question from the Fayette Institute of Technology is, are the lenses, are they one size fit all, or are there different sizes?
Yes, very great question. Actually, we do a measurement before the patient goes into cataract surgery. The length of the eye and the curvature of the cornea is going to affect what kind of implant you get. So you could get, there are many different diopters. So just like when you go to the eye doctor and you get different eyeglasses, and they measure you with the machine, 1, 2, 1, 2. So once the patient is getting a lens inside their eye, the process is the same. We have to match the length, the curvature of their eye to give them the best implant possible, so that their vision is going to be clear and in focus when they're trying to do their activities. The size of the implant itself, so the diameter and diameter of the optic, the diameter of the haptics, that is a standard implant. So okay. that doesn't change. It will change for adults and children and things like that, but that's a standard implant. The part that changes is basically the strength of the implant to match the person's length and curvature.
Okay, one of the questions kind of dealt with that is, can the lens become cracked, the acrylic lens, if there's too much pressure or anything like that?
So not typically. That's a very durable material. It's unlikely that that's going to happen. It's more likely that it could shift or change position within the eye. And that even is very rare. So if we talk to many ophthalmologists, the majority of them will say that throughout their careers they never had a lens move. And so that's very, very, very rare to happen. So it's a durable material. It doesn't usually will develop cracks or problems with the material itself. If patients have problems in the future, it may have something to do with developing a little bit of a film on the bag itself that holds the lens. And if that film develops, then we can do laser to clean up the film after having cataract surgery. But that usually doesn't affect the implant or the life or the quality or the durability of the material.
We had a couple questions from Twitter that are kind of related. Number one is there anything you can do to prevent cataracts?
Well, that's a great question. I mean, I think that when we go into that, we go into a little bit of the realm of science fiction right now, because can we prevent aging? Not yet. Maybe in the future, but as it is, we can't prevent aging. So the processes that are associated with aging are going to happen no matter what. Now, if we're talking about specific things that cause cataracts, like we did in the beginning, maybe steroids or trauma and things like that, those things you can avoid and try to prevent it. But there's not a specific pill or a drop or a shot or anything as it is now that can prevent that. But people are working on that. And I think that during my career, hopefully, we will have other ways that deal with cataract that don't involve surgery alone. So maybe some medical things, maybe a drop, maybe something that would strengthen the antioxidant properties of the eye to maintain the clarity of the lens. So we're not there yet, so maybe in the future. Yeah.
Well, so what happens if you don't treat the cataract? What happens to the patient?
Yeah, I mean, if you don't treat the cataract, the patient is going to continue to have the lens that they have, the natural lens of the eye, and it will continue to go through the process of aging. So many people could go into their 80s or 90s and feel very comfortable doing the things they like to do. So let's say they like to do puzzles, or they like to read the newspaper or watch TV. If they're doing these things comfortably without feeling like there's something being robbed from their experience, they don't need cataract surgery, but the cataract itself is not going to go away or improve. It's only going to either stabilize or get worse.
Okay. And when we're talking about implanting the acrylic lens in, in other procedures we've talked about here, we've talked about, the body, whether it rejects or accepts the implant. Do we have a problem with the eye?
Yeah, not typically. So we talked a little bit about what kind of, how do they come to this particular implant. There's different kinds of implants. There's PMMA implants, there's acrylic implants, and basically the best quality for an implant is that it's durable, it's transparent so that it's clear, and that it's going to be inert in the eye. So if you put something in the eye, and you would know that if anybody has had an accident where they got metal in the eye, even if it's just in the cornea, so not inside, but even just in the surface of the eye, they will know that that's a very reactive material. You develop a rust ring right away, and then you could have issues with the eye developing an inflammatory response against all those different things. Vegetable materials, certain metals, they elicit great responses from the eye. The acrylic, the PMMA, and all the different things that we currently use for implants in the eye are inert. So they go inside the eye and they don't develop an inflammatory response in the eye. There is an inflammatory response in the eye naturally because of having surgery. So we made cuts in the eye, we introduced an ultrasound machine to the eye. These different things will elicit an immune response from the eye, so there's going to be an inflammation there, but not necessarily from the implant.
So after the procedure, if there's any infection or anything like that, how do you treat that?
Well, an infection in the eye is a devastating thing. It's called endophthalmitis, and if you have an infection in the eye after having cataract surgery, it's unlikely that you're going to be able to see well. But that's very, very, very rare. So it's 1 in the 10,000, 100,000 realm. So like I said earlier, I was talking about the shifting of the lens, but the majority of ophthalmologists will go their entire career, 30, 40 years, doing cataract surgery and never have an infection. And that's a great thing. But if the patient does develop an infection, then you have to treat it very aggressively from the get-go. And you will do shots in the eye itself for giving the antibiotics inside the eye. And you will give antibiotics the whole time outside with drops. So you would do drops that are antibiotics, you will do a shot that's antibiotics, and you will monitor that patient very, very, very closely and hope that they can recover. But an infection in the eyes, it's a devastating process.
Now, can the patient feel the implant in the eye?
They cannot. No, that's a great question. And why not? Well, that's because there are parts of the eye that have lots and lots and lots of nerves. As we know, if we get anything in the eye, like even an eyelash, you'll be bothered like severely because the cornea and the conjunctiva have tons of nerves. Also the iris, as we talked about in the beginning, I had to put a little bit of numbing inside the eye because of the iris. But the back of the lens where you put that new implant, and the lens itself, no nerves. So no, you can't feel anything.
Now, is there a chance that the cataract can come back even after you've replaced the lens?
No, not typically. So that's a dual question though, because the cataract itself, by definition, is the opacity in the natural lens of the eye. So if I remove the lens, there is not any cataract that can come back. Right. However, these lenses, or the lens is made out of these tiny little cells that they're constantly making more lens, more lens, and more lens. So once you remove the cataract, you do the best job you can to get all of that cataract out and all of that material from the eye. But those little tiny cells, you cannot see them even with the microscope. So if there are some cells that are left over, they can create a little film in the bag itself, and that's the one that we clean off with laser. So
we got a few more questions coming in. Who would not be a candidate for this type of procedure?
The people who would be difficult for us to do surgery on are the people who cannot, they may not have very good cognitive ability to deal with the pre-op and the post-op process. So as we mentioned, after having surgery, you have to do all these drops. So in little kids, you can do that because the parents are the ones taking care of the kid, and that's usually a process that is possible. But a lot of times, you will have an elderly patient who is maybe in a nursing facility and they don't have the ability to care for themselves very well, in which case they it may be difficult for them to do the post-op process. I specifically am thinking of people who have Alzheimer's, or who have a mental retardation, or people who have problem with cognitive ability. So it's a very delicate process with these patients because obviously their vision is starting to be affected, and it's affecting the way that they interact with the world. But when I do surgery for the eye, I use a sutureless approach. So I don't put a stitch in the eye. And so if you push strong enough, or if you rub the eye severely enough, you could open that wound. And if you open the wound, so eye contents can come out, which is terrible. But even worse, you could introduce things into the eye, which would end up with endophthalmitis, or infection in the eye. And that is very bad. So patients who have problems with their cognitive ability, so if they are going to rub the eye, or if they're going to reach into the eye, or they cannot properly care for the eye after the surgery, those are the people that we're very, very cautious about doing surgery, because we have to ensure that their caregivers can protect them that way.
If you perform this procedure on a younger person, a child, and they continue to grow, how does that affect the size of the lens and the replacement?
That's a great question. You know, there's different schools of thought. When is it that you put an implant in the eye like this, or when is it that you just correct the vision of someone that young with just contact lenses. So there's different schools of thought, and I'm not necessarily a pediatric ophthalmologist to say I prefer this school or that school, but in brief, yes, the eye is going to continue to grow. So if you put an implant that's based on what the size of the eye is, you know that in the future the patient is definitely going to need glasses or correction. You can also put the implant in the eye that you wait a bit longer, so about maybe until they're 1 year of age or a little bit older, to put an implant in the eye that you feel is going to be what they're going to need. But then you need to correct their vision up to that point with contact lenses or glasses. So that's the way that you have to approach that problem.
So how often do you perform this procedure?
My typical week will be once a week. I will do this procedure. We have a surgical day on Tuesdays. I come in, I do surgery on however many patients we schedule for surgery that day. And then I will see them one day after surgery, 1 week after surgery, and a month after surgery. But I have, as it is now, a small volume of cataract patients that are needing cataract surgery. And that's the nature of a new practice, which started just about a year ago. Ophthalmologists they've been operating for a long time. And I have a few colleagues here in the area, they've been operating for 20, 25 years. They will operate sometimes twice a week, and they're going to do many patients in a day, maybe 17, 20 patients in a day, twice a week. So that you can do the math, and some of these people will do, even hundreds to thousands of cases in a year.
Mm-hmm.
So,
now, just to clarify, we had a question on Twitter, but when you correct the cataract, you're not correcting any other vision problems that somebody may have. So if they had a need for glasses or contacts or anything like that before, you're just restoring it back to that?
Yes and no. So first of all, we talked about if they have a problem that limits their potential for vision with the optic nerve or retina, then I can't do anything about that. But I can help them if they have, let's say, if they're nearsighted or if they're farsighted, or if they have astigmatism. There are ways that we can, the new lens that we're going to put in the eye kind of works by proxy as if you had a lens outside of the eye. So if you needed glasses or contact lenses beforehand, we can correct that with a new implant. So usually people get a standard implant which just corrects one aspect of their vision. Let's say that they were nearsighted before. I can make them plano, or in other words, they will see perfectly for distance now. But they are not going to be able to see for near. And vice versa, if they were farsighted, I can correct for that. And if they have astigmatism, there are lenses that we can put inside the eye that can correct for astigmatism. Now, when we go into that realm, we're talking about lifestyle lenses or special corrective lenses. And in this particular case here, I have in my hand a toric lens. It has these little tiny, it may be hard for people to see, it has little tiny dots on each end where the haptics and the optics meet, and that corrects for astigmatism. I have another lens here that is called a multifocal lens, which will correct for, it has all these different rings inside of the lens itself, so it's different than a standard lens, which only be clear on the inside. But these different rings will work by diffraction and actually correct for near and farsightedness. Okay. So the short answer to the question is yes, we can correct nearsightedness or farsightedness or astigmatism so that you could have glasses independence after having cataract surgery.
As long as it's on that side of the eye?
Yeah. Not on the back part.
Right,
yeah.
Okay. Mm-hmm. So how much schooling and training did you go through before you could do this?
So after college, you do medical school. So medical school is typically 4 years if you stay on track. And then after that, you do an internship. And so that's another year. And then you do ophthalmology residency, which is another 3 years. So the medical training itself is typically 8 years. To do this sort of surgery. But then for you to be able to get into medical school, you will have to have typically a college degree, and then you have to take those prerequisites that they require for the specific medical school you want to go to, and you have to take the MCAT.
Okay. So you spend a lot of time learning medicine and learning about the eye specifically.
Yeah.
And all.
But hopefully, once we're, whoever's doing surgery, and your grandma and your mom, you know that they're trained well to do it.
Exactly. You've spent several years working on it.
Yeah.
Well, we really appreciate you being with us today. We appreciate the patient for agreeing to do the surgery and to talk with us afterwards and everything. That really helps.
Yeah, for sure.
Helps out, so we can explain to students both the medical pieces of it and also the careers and everything. So we appreciate you.
Yeah.
And the eyesight certainly is a gift that we sometimes take for granted. We're going to close out the show, and as we do, we are pleased that so many of you sent in your questions to us today. Be sure to keep watching on Twitter. Refresh your timeline using the hashtag ImagineU. And follow CAMC_HS, and we'll keep answering the questions that are still out there. Any that we did not get to, and any that come in as we're closing. So be sure and refresh your timeline and follow ImagineU, hashtag ImagineU. Don't forget to complete the survey online. It's at this same website. Give us your feedback for today's presentation. CAMC.org/ImagineU is the site to go to. We use your comments to make changes and make improvements for future programs. And for any of those who are interested in a career in the medical field, we are pleased to announce that we're going to have our first ever Healthcare Career Showcase. It's scheduled for Saturday, April 9th, 2016. It'll be held at the Charleston Civic Center. A lot of plans and preparations are going into that right now. We'll have more information between now and then. Colleges and different healthcare professionals are going to be on site. What we want to do is help you create a roadmap to figure out what you need to do, what schools you need to go to, the education you need to become whatever healthcare professional you want to be. And also mark your calendars for the week of July 11th through the 15th next year. It is Career Awareness Week. You can come, tour in the hospital, meet and talk with different professionals, clinical professionals, and others who work in the hospital setting. This is for students from 9th grade to 12th grade. And again, more information will be coming for that in the spring. Again, we thank you for watching the webcast. ImagineU is a collaborative effort of the West Virginia Department of Education and Charleston Area Medical Center. And as we leave, you'll see some of the names of the people who worked on today's webcast. Thank you, and have a great rest of the day.